A 40-year-old male presents with persistent forearm pain following a minor injury. I am showing you AP and lateral radiographs of the forearm and a sagittal computed tomography scan of the ulna. Please describe the findings.
The radiographs demonstrate an elongated, centrally located lytic lesion in the mid-distal ulnar diaphysis, showing a well-defined, scalloped sclerotic border. The computed tomography scan confirms a homogeneous ground glass matrix within the lesion.
What is your primary diagnostic concern?
The findings of a well-defined, expansile diaphyseal lesion with a classic ground glass matrix and a surrounding rind of sclerosis are diagnostic of fibrous dysplasia.
What is the underlying pathophysiology of fibrous dysplasia, and does it represent a true neoplasm?
It is not a true neoplasm, but rather a benign skeletal developmental anomaly of bone-forming mesenchyme where normal bone marrow is replaced by fibrous tissue and immature, woven trabeculae due to osteoblast maturation arrest.
What are the two main clinical forms of this disease, and what is their relative frequency?
The two forms are monostotic, involving a single bone, and polyostotic, involving multiple bones. Monostotic fibrous dysplasia is much more common, accounting for 70 to 80% of cases.
What is the classic radiographic term for the skeletal deformity of the proximal femur seen in severe polyostotic disease?
This is known as the shepherd's crook deformity. It represents a severe coxa, varabowing deformity of the proximal femoral neck and shaft, resulting from repeated microfractures in plastic bone.
What syndrome is characterized by polyostotic fibrous dysplasia, café-au-lait spots, and endocrine dysfunction, and in which gender is it most prominent?
This is McCune-Albright syndrome. It is most prominent in females and is classically associated with precocious puberty.
What is Mazabrod syndrome?
Mazabrod syndrome is a rare association characterized by fibrous dysplasia, typically the polyostotic type, coexisting with multiple soft tissue intramuscular myxomas.
Finally, what are your clinical management recommendations?
Asymptomatic lesions can be managed conservatively with clinical and radiographic monitoring. If the lesion is painful or large, I recommend a skeletal survey or bone scan to rule out polyostotic disease and referral to orthopedic surgery.